Pediatric Radiography with Brandy Jones. Introduction, room prep, and technologist's attitude. Properly preparing the room for a pediatric patient can reduce the time the child is in the room. Remember, pediatrics could be scared, confused, hurting, or a combination of all three. Keep in mind, they have never been in an X-ray room before. Keep in mind, sometimes they have been poked and prodded, meaning blood draws, IVs, breathing treatments, swabbed for COVID or flu. Sometimes moving the equipment before the child arrives may be less stressful and less anxiety for the child than when they arrive. Children can be difficult, but your approach and patience is necessary for success. Introduction, age of understanding and cooperation, pre-exam introduction and child and parent evaluation. Children vary. However, by 2 to 3 years old, most children can be talked through a diagnostic procedure without immobilization of a parental aid. Introduction of the tech. It is important to introduce yourself, get down on their level, and explain the procedure in simple, easy terms. Communicate in a language that they can understand. Also, communicate with the parent and/or guardian. Parent involvement. 3 options. Observer in the room. A parent in the room as an observer, lending support and comfort with his or her presence. A participant in the procedure. A parent actively participates and assists. A parent non-participant out of the room. A parent is asked to remain outside the X-ray room. Sometimes children may be more cooperative without the parent in the room. Assessment of the parent is important and requires you to be objective. Immobilization. A. Pigistat. B. Digital imaging immobilizer. C. Some positioning aids. And lastly, D. Tamum board. Generally, parents would prefer to help with immobilization of their own child. A parent must not be pregnant and must be properly shielded. Communicate with the parent for proper immobilization and assisting tend to increase the quality of the images and will reduce the chance of a repeat. Other forms of immobilization that could be used: tapes, sheets, towels, radiolucent sponges, compression band, ACE bandages. Short exposure times should be selected to reduce possible motion. Immobilization. Wrapping with a sheet or towels. Mummifying. Step 1. Place the sheet on the table and fold in half or thirds lengthwise. Step 2. Place the patient on the sheet with the right arm down to see the right side. Fold sheet across the body, keeping the arm against the body. Step 3. Place the left arm along the body of the top of the sheet. Bring the free sheet over the left arm to the right side of the body. Wrap the sheet around the body as needed. Step 4. Pull the sheet tightly so the patient cannot free the arms. Bone development. A fun fact: kneecaps started out as cartilage, unconnected from the rest of your skeleton. Patella start out as soft tissue and ossify into hard, strong bones we all know by age 3. So if you are a 1-year-old, you have no patella. Fun fact: you are born with about 300 bones and end up having 206. Many bones, like in your skull, fuse together as you grow. Bone development. A picture of a long bone. Okay, you have the epiphysis, the metaphysis, the diaphysis, which is the shaft, and the medullary cavity. Bone development. The epiphysis of the knee at 3 years old is not visible yet, but yet at 12 years old it is evident. The epiphyseal plate found until skeletal growth is complete to a full maturity. Normally, it occurs at approximately 25 years old. Child abuse, suspected non-accidental trauma, SNAT. An older term is battered child syndrome, BCS. Okay, professional responsibilities, know the state of statute and technologist responsibilities, know institutional reporting protocols. Radiographer is more likely to be exposed to non-accidental trauma of children, more commonly referred to as child abuse. Most abuse occurs in children under 3 years old, with the highest victim rates in those younger than 1 year. Radiology is an important tool, and quality images are a must. Child abuse classifications. 6 major types. 1. Neglect. 2. Physical abuse. 3. Sexual abuse. 4. Psychological maltreatment. 5. Medical neglect. And 6. Other. Child abuse, radiographic indication, a classic metaphyseal lesion, a CML, rib fractures, and healing fractures. A CML is a specific fracture that has a high indication for child abuse, and CML is one. CML is a fracture along the metaphysis that results in tearing or an avulsion of the metaphysis. Another name is more commonly known to as the corner fracture or a bucket handle fracture. A corner fracture seen in picture A, and a bucket fracture seen in picture B. It will appear as a crescent-shaped osseous density adjacent to the avulsion fragment. See the arrows. CML is caused by forces exerted on metaphysis, for example, pulling an extremity, or from holding a child around the thorax and shaking violently, as seen in shaken baby syndrome. Classic abuse radiographic indications. CML, which we've already talked about, rib fractures, and healing fractures. Rib fractures, especially multiple and posterior, are a strong indicator of child abuse, seen in shaken baby syndrome when hands are held under the axilla and shaken. A force is exerted in the anterior and posterior direction, and it is enough force to fracture multiple ribs. Squeezing the thorax can cause costovertebral as well as scapular and spinous processes posteriorly in the sternum anteriorly. All are indications of child abuse. Healing fractures. Fractures in multiple stages of healing can also raise suspicion for child abuse. However, a thorough history is important. Multiple fractures could also reveal osteogenesis imperfecta found in children. Here is an image of a pediatric, and the arrows are pointing to multiple fractures in the posterior rib. The skeletal survey. Different departments have different protocols, but usually we'll do AP and lateral skull. Lateral usually will include the cervical spine, an AP and a lateral chest, a right and a left oblique thorax. This includes the ribs, an AP abdomen to include the pelvis, a lateral lumbar spine, an AP humeri, both of them, right and left, AP right and left forearms, a PA hands, right and left, AP femurs, right and left, and AP lower legs, right and left, and AP feet, right and left. Images should have close collimation and proper technique. Do not put through modeled images due to inadequate technique. The better the image, the better the chance the radiologist can read the image properly. Each cone down image is important. Center properly and do not perform babygams. Alternative imaging modalities. CT. Advantages include visualization of the visceral damage, especially with abdomen, head, and skeletal fractures. Diagnose brain injuries from shaken baby syndrome. MRI. Assessing soft tissue and central nervous system damage. MRI is not generally the test of choice due to the length of time a child must hold still for. Ultrasound. Imaging visceral damage such as hemorrhage, and certain skeletal damage, plus no radiation. Nuclear medicine. Useful for healing bone, visualizes bone in multiple healing stages. This is often in conjunction with a skeletal survey when multiple fractures are found. Radiation protection and image gently. Image gently. A campaign to raise awareness of increased pediatric dose rate. In radiography, this means protocols such as 1. Limiting the use of grids for parts less than 13 centimeters. 2. Collimation of the part size. 3. Increase KVP to decrease MAS exposure. 4. Being consciously aware of the relationship of the patient thickness, technique, and exposure value lead to reduction of dose for more radiosensitive pediatric patients. You can go to imagegently.org to see more. Minimize exposure dose. Proper mobilization, short exposure times to reduce motion and blur, no grid unless the body part measures more than 13 centimeters. See proper technique charts for peds in your department. Gonadal protection. Children's gonads should always be shielded. Sometimes with abdomen and pelvises, the shield may obscure substantial anatomy. For those insistent parents that move the lead shield or want the shield in the way, explain that other safeguards are made, like low-dose techniques, collimation, and the minimal amount of exposures, with their help, will ensure success. Parent protection. If a parent is needed in the room, a lead apron must be provided. Keep the hands out of the primary beam while holding the child. Provide lead gloves if the hand may be in the primary beam. Females of childbearing age, ask about pregnancy. Pre-exam prep. Have the room ready. Any necessary immobilization devices have out. Shielding paraphernalia in place and easy to put on. The X-ray tube moved into position and lined up to the IR. Have your technique preset. Digital imaging considerations. Collimation. 4-sided collimation is optimal for quality. Accurate centering. The CR must be accurate to provide high quality. Exposure factors. ALERA, as low as reasonably achievable. Lowest exposure factors to obtain quality images. Higher KV, shorter time to reduce motion and blur. Post-processing evaluation of the exposure indicator. Check for the acceptable exposure in an acceptable exposure range allotted for your equipment. Grid. No grid unless it's over 13 centimeters. Pediatric indications. Pediatric chest, aspiration, asthma, croup, cystic fibrosis, epiglottitis, hyaline membrane disease, meconium aspiration syndrome. These are found in your Bontrager's. Make sure you review them. Clinical indications for pediatric skeletal system. You have craniostenosis, development dysplasia of the hip, idiopathic juvenile osteoporosis, osteochondroplasia, osteochondrosis, osteogenesis imperfecta, infantile osteomalacia, Salter-Harris fractures, spina bifida, and clubfoot. Salter-Harris classification, only used for pediatric fractures that involve the growth plate, the physis. Salter stands for S, straight across, a fracture of the cartilage, the physis, the growth plate, transverse fracture through the growth plate. A, above, the fracture lies above the physis or away from the joint, a fracture through the growth plate and the metaphysis sparing the epiphysis. L, lower or below, the fracture is below the physis or the epiphysis, a fracture through the growth plate and the epiphysis, sparing the metaphysis. T, through everything, the fracture is through the metaphysis, physis, and the epiphysis. A fracture is through all three elements of the bone: the growth plate, the metaphysis, and the epiphysis. R, or ER, erasure of the growth plate or crush. The physis has been crushed, a compression fracture of the growth plate, resulting in a decreased perceived space between the epiphysis and metaphysis on an X-ray. And here are your examples that go along with that. S is number 1, A is 2, 3 is L, 4 is T, and 5 is ER. Pediatric abdomen, summary of indications are listed here. Again, make sure that you are looking in your Bontrager's for these: hematuria, Hirschsprung's disease, intestinal obstruction, necrotizing enterocolitis, polycystic disease, polynephritis, hypertrophic pyloric stenosis, tumors, urinary tract infections, vesicouretal reflux, atresia. Pediatric radiographic positioning. All right, it's time to take some x-rays. An AP chest infant. This patient is in a supine immobilization device called a TMM board. You can use other mobilization devices if this is not available. However, you want to try to get 50 to 6 inch SID, non-grid. The IR is lengthwise with the baby. Your shortest exposure time possible. Shield your gonads, mark in the upper right or left corner. Place the baby supine. Your central ray is perpendicular to the IR, centered to the mid-sagittal plane at the level of the mammillary line. And collimate all 4 sides. Make your second full exposure on inspiration. However, if the baby is crying, you need to watch the respirations and expose after full inhalation. See your Bontrager's for any additional information. Lateral infant chest. You still want to try to get 50 to 60 inch SID, non-grid, lengthwise with the baby. Shortest exposure time, you're still shielding the gonads. You want to mark anteriorly in the neck area. And use the side closest for to mark. The baby should remain supine. Place the baby next to the IR as seen in these pictures. So we will be shooting a horizontal beam centered to the mid-coronal plane at the level of the mammillary line. Collimate all 4 sides, and again make your exposure on your second full inspiration. For the crying baby, watch respirations to expose after full inhalation. PA chest, toddler, erect PA, and the picostat is seen here. The SID will be 72 inches, non-grid. However, this is up against a chessboard, but make sure you take the grid out. It is extremely important. Take the grid out. Do not use the grid on child. It's too much exposure. See your Bontrager's for the rest of the information. Do not use your own markers. Use this and use a better shield. I will go over that. I have a little video for you guys. Lateral chest. Erect lateral in a picostat, 72 inch SID, non-grid. For PA and lateral chest or AP chest, ensure proper rotation technique. The lungs are fully expanded. You should be seeing 9 to 10 ribs above the diaphragm. You want to see a sharp outline of the diaphragm, see lung markings through the heart shadow, no motion. Make sure you guys see your Bontrager's for the information you need for what you see. Upper extremity, AP and lateral. Department protocols vary at different facilities. A unilateral upper extremity is an AP and lateral of the entire upper extremity from the shoulder joint to the fingertip, usually performed on a 1-year-old or younger. Whereas an upper arm could be in humerus, AP, and lateral at other facilities. The SID will be 40 inches. Your IR will depend on the size of the body part, non-grid, shortest exposure time possible, collimate down to the part, shield radius sensitive area and gonads. Place the IR under the affected arm to include both joints. A true AP, supinate the hand and extend the arm out in an AP. Lateral, abduct the arm and flex at 90 degrees at the elbow. Try to keep in the same plane, the wrist in the lateral position. Central ray is midpoint of the extremity. See your Bontrager's for the rest of the information. Upper extremity, AP and lateral. Ensure there's no rotation, that all pertinent anatomy is included. Collimation of borders are evident. Optimal exposure factors are used. Lower extremity, AP and lateral. Again, department protocols may vary at different facilities. A unilateral lower extremity is an AP and a lateral of the entire lower extremity, from hip joint to toe tips, usually performed on a 1-year-old or younger, whereas a lower extremity could be a lower leg, a tib fib, an AP and lateral at other facilities. You will need to find out what the protocol is for your site. Pelvis and hips, AP and lateral. Department protocols may vary at different facilities. They may be bilateral or unilateral hip protocols. The SID will be 40 inches. The IR depends on the size of the part to be radiographed. Your IR would also be crosswise, non-grid, unless under 13 centimeters. Shortest exposure time possible. Mark laterally. The patient is supine to ensure no rotation. For the AP, internally rotate your feet and knees, just like we do for the adults. In lateral, abduct the legs, place the soles of the feet together, and bend and abduct. Bind the soles if needed. Pelvis and hips, AP and lateral. Ensure no rotation, no motion. Correct placement of the gonadal shield, not to obscure any important anatomy. Optimal exposure factors are given or used. Skull. AP reverse Caldwell, AP town, and a lateral should be performed. Skull, SID 40 inches, IR determined by the body part size, collimate down, grid if measures more than 13 centimeters, shortest exposure time possible, shield radiance sensitive tissues outside the region of interest, your gonads. Mark your lateral corner, upper corner, immobilize as needed, patient supine, position the head with no rotation. Your OML should be perpendicular to the IR. The CR should be centered to the glabella. For AP skull, your central ray is parallel to the OML. For your AP reverse Caldwell, central ray is 15 degrees to the OML. For AP town, it is 30 degrees caudal to the OML. Ensure no rotation, no motion. Make sure the proper relationship between the orbits and the petrous ridges are evident. Optimal exposure factors will apply. Make sure you guys are looking at your Bontrager's to fill in all the other information. A lateral skull. SID 40 inches. The IR determines on the patient's size. Make sure you're collimating all the way down. Non-grid unless they measure more than 13 centimeters. Shortest exposure time possible. Shield your radiosensitive tissues. Mark anteriorly outside the region of interest, closest to the IR. Central ray is midway between the glabella and the occipital protuberance, or the inion, which is 2 inches above the EAM. With a Taman board, a horizontal beam, and a head and true lateral can be done. With an infant mummified, a perpendicular to the IR at the head and true lateral. Make sure for the skull lateral, there's no motion, no rotation or tilt. Ocella and Terzica and the clivus in profile without rotation. Optimal exposure factors are used. An abdomen, AP supine, KUB. SID is 40 inches. The IR is determined on the patient of the size of the patient. A non-grid unless measures more than 13 centimeters. Shortest exposure time possible. Shield your radiosensitive tissues outside the region of interest. The patient is supine, immobilized if needed. For central ray for infants, it's 1 inch above the umbilicus and mid-sagittal plane. For your toddlers and up, it is at the iliac crest and mid-sagittal plane. Breathing, infants watch respirations when the abdomen is still exposed. Try to do it on expiration. If the patient is crying and takes a breath in and let it out to cry, then expose. Toddlers and up, have them hold their breath. In AP KUB, the vertebral column is centered, all pertinent anatomy demonstrated, diaphragm to symphysis pubis, no rotation, no motion, optimal exposure factors are used. Abdomen, AP erect. SID is 48 inches. The IR is determined by the patient's size, collimate down to your part size. A screen non-grid should be used unless larger than 13 centimeters. Use your shortest exposure time. Shield your radiosensitive tissues outside the area of interest. For a patient, you can use erect. You can sit or stand, immobilize as needed. If you are using a chest bucky like seen in picture 1, make sure you're taking the grid out. Your central ray for infants is 1 inch above the umbilicus and mid-sagittal plane. For toddler and up, it should be 1 to 2 inches above the umbilicus and mid-sagittal plane. Breathing, make sure you watch your respirations. If crying, make sure you watch to expose. And toddlers and up, make sure you hold your breath. In AP erect, make sure your vertebral column is centered, all pertinent anatomy is demonstrated. You want to see your air fluid levels, diaphragm included. Ensure there's no rotation, no motion, and optimal exposure factors are used. AP lateral decubitus, 40-inch SID. Again, you need to collimate down to the size of your part. Non-grid unless they measure larger than 13 centimeters. With the short exposure time possible. Shield your radiosensitive tissues. The patient may be laying on a sponge. Ensure no rotation. Immobilize if needed. Horizontal beam centered to MSP, and for infants it's 1 inch above the umbilicus. And for toddlers and up, it's 1 to 2 inches above the umbilicus and mid-sagittal plane. Again, watch your patient for your breathing. Abdomen dorsal decube. The SID is 40 inches. Make sure you're collimating down to your part size. Non-grid unless they measure more than 13 centimeters. Shortest exposure time possible. Shield your radiosensitive tissues. Your patient is laying AP on a radiolucent sponge. Ensure no rotation. You have a horizontal beam centered to mid-coronal plane. Infants 1 inch above the umbilicus and mid-coronal. Toddler 1 to 2 inches above the umbilicus and mid-coronal plane. Again, for breathing, watch your patient. So for the dorsal decube, your diaphragm is demonstrated. You should ensure no rotation, no motion, and optimal exposure factors are used as evident here. Pediatric fluoro studies, barium swallow, upper GI, small bowel, and BE. Upper GI prep. Patient prep, use the complete history, early morning schedule on an empty stomach. Infants younger than 3 months, NPO 3 hours prior to the procedure. Children 3 months to 5 years, NPO 4 to 5 hours prior to the procedure. children 5 years and older. NPO 6 hours prior to the procedure. And this chart was courtesy of the Children's Hospital in Denver. Upper GI room prep. Make sure your table is horizontal. You have a sheet on the table, feeding bottle and nipple ready to go, feeding catheter and syringe, suction and oxygen and immobilization devices may all be needed. For suggested amounts of barium, possibly diluted depending on your radiologist. Sometimes they add water. Newborns to 1 year would be 2 to 4 ounces. 1 to 3 years would be 4 to 6 ounces. 3 to 10-year-olds would be 6 to 12 ounces. And over 10 years would be 12 to 16 ounces of barium. Upper GI fluoro positioning sequence, supine, left lateral, LPO, RAO, right lateral, and prone. The small bowel follow through, 20 to 30 minute intervals, PA and or AP projections. However, PA is always preferred, especially with pediatrics. Ileocecal region in 1 hour is usually the average for a child. Post-procedure instructions. Make sure you have them try to drink water. Equipment. Single contrast PE. You're going to need lubricating jelly, hypoallergenic tape, gloves, washcloth, and towels. For neonates and infants, a 10 French silicone catheter, a 60 milliliter syringe. Single contrast PE. For children over a year, a disposable enema bag, a pediatric flexible enema tip. Do not use latex or an inflatable balloon enema tips. Air contrast enema kit with double line tip. Clearly explain to the parents and the patient pre-exam would be an AP KUB, a scout, your fluoroscopic films, and then afterwards the radiologist may ask you to take some projections, usually a supine or a prone KUB, your right and left acute with double contrast, and a post-evac film. Make sure you give the patient instructions upon leaving. They might see white stool, etc. Post-reduction of intussusception after air or barium enema. AP supine KUB is taken to demonstrate that intussusception has been reduced. Image on the right demonstrates this by the presence of air in the ileum. Genitourinary system voiding, cystourethrogram, VCUG, and IVU prep. The VCUG patient prep, there's no specific patient preparation needed. The IVU preparation, no solid food 4 hours prior to the exam. Encourage drinking of clear liquids. VCUG, prior to the IVU or sonogram. UTI, which is a vesicoureteral reflux, sometimes demonstrating during the voiding phase. This is an example of a 16-day male AP and oblique images demonstrating vesicoureteral reflux on both kidneys. Room and patient prep for the VCUG. Your table is in horizontal position with your fluoroscopic tower being used. Your contrast media is ready on an IV stand. Explanation of the procedure and patient privacy is important. Procedure. Void. Prior to the procedure, your catheter is inserted, the bladder is filled slowly by gravity. Fluoro and images before, during, and after the voiding phase, and post-procedure imaging is optional for the radiologist. They may ask you to take some, as seen in adults. Centers for Disease Control and Prevention. I would like you guys to check this website out. Go to cdc.gov, violence prevention, child abuse, and neglect. The technologist should have an understanding of the laws surrounding the reporting of child abuse at your healthcare site. The technologist may not initiate reporting process, but if you have a strong suspicion, you must alert the charge nurse or physician. Chances are they already know, but it's our responsibility to The technologist must remain professional, do not pass judgment, and please provide optimum quality radiographs. The images produced will be used by the radiologist to give diagnostic opinion and can be used in court for prosecution or defense. That's it.